Let's get started. Welcome, everybody. This is the VCU Department of Internal Medicine Grand Rounds. Today is October 17, 2024. This is one of our special Grand Rounds. We have each of our 11 divisions hosts 2 Grand Rounds every year. This is brought to you all by the Division of Cardiology here at VCU. Today's speaker is Dr. Carolyn Burns. She's going to be talking about evaluation of risk, cardiovascular risk, and the role of lipids. Dr. Carolyn Burns is an associate clinical professor in the Division of Cardiology here at VCU with over 35 years of experience as a cardiologist, a lipidologist, and an advocate leader. She's a native of Ohio and attended Youngstown State University, combined bachelor's in medical program with completion of medical school at the University of Pittsburgh. She completed her internal medicine residency program at University of Pittsburgh and her cardiology fellowship here at VCU. After her cardiology fellowship, she worked in private practice for more than 29 years before returning to VCU part-time to focus on lipid management and preventative cardiovascular medicine in November of 2023 here at VCU. She's long been an active leader in the service to Virginia and to Richmond as a leader of Richmond Academy of Medicine, where she served as president, and in various leadership roles at the Medical Society of Virginia. She successfully has navigated and engaged state legislators on various issues over the years that physicians need to provide some perspective on and take a key part in grassroots advocacy, improving the lives of patients, staff, and fellow physicians here in the Commonwealth of Virginia. Today's talk will be on the evaluation of risk and the role of lipid management and preventative cardiovascular medicine. Please help me in welcoming Dr. Burns to share her thoughts. There you go.
Okay. Well, good afternoon, everybody. I want to thank Dr. Syme and also Dr. Bergman for inviting me to speak today. We're going to be talking about stratifying risk, which is not a very sexy title, I realize, but it's something that we do all day, every day, and a lot of times we don't even think we're doing it. But I think it's important to understand how we come up with decisions that we make day to day. I have nothing to declare. So the goals for today are to consider lipid and lipoproteins and the guidelines for their treatment. I'm also going to help you understand a little bit better about Apo lipoprotein B, and also look at the use of coronary artery calcium scoring in a risk assessment. And finally, hopefully, garner some referrals to our lipid clinic. So to talk about risk, we have to identify the risk and the potential consequences, also the probability of risk occurring and the tolerability of the risk, and then ways of mitigating or reducing the probability of risk. So just some things to have in the background of your mind as we talk today about various situations where we're looking at risk. So starting back at the beginning, well, almost at the beginning, the timeline of discovery of HMG-CoA reductase began back in 1960, where that part of the pathway was discovered. This young gentleman here in the picture is Dr. Akira Endo, who was a Japanese man who found some fungus that was found to be an inhibitor of HMG-CoA reductase. And by working with Sankyo and Merck, they came together and discovered mavenelin, which is lovastatin. And that was our first statin that was approved back in 1987. And I personally remember that very well because I was in the middle of my internal medicine residency. So here's a list of the statins available today. Often statins are available in different intensity groupings because you can use a low dose and have one intensity and a higher dose and another intensity. But you can see here that we have many options to use statins for reducing risk in our patients. And basically, statins have become the first and foremost medication tried for reduction of ASCVD risk because we have used them for so long. They are inexpensive and they work very well. So how do we apply risk when we are prescribing statins? There are many potential side effects to statins, but there was a lot of concern early on in some things that just didn't pan out, such as the effect on cognition. There's been no evidence that cognition is adversely affected by being on a statin. I have anecdotally seen patients who feel on some statins like they have brain fog, but usually you change the statin and that goes away. Hemorrhagic stroke was also a concern, not felt to be so, other than one study said that if you had a prior stroke, you might be susceptible to another stroke if you're on statins, but really not a strong signal. No evidence for increased risk of cataracts. And the effects on the liver are basically minimal. Usually it's a mild transaminase increase. And if it's less than 3 times upper limit of normal, we usually just watch it. Other more severe effects on the liver are very rare. Proteinuria also low frequency of issues there. The big 2 things that people are most concerned about are muscle symptoms, which are fairly frequent. In double-blind placebo-controlled trials, they're very minimal, but that's because people have a washout phase typically in these trials. And so all those who are going to have symptoms get weeded out. But in non-blinded studies, anywhere from 7 to 30% of patients are going to have some type of muscle symptoms on a statin. And we'll get to how we deal with that in a minute. We also have a concern that patients are very aware of these days, and that is new onset diabetes. It happens about 0.1% per year. And it typically is involving people who are already at risk. So they're pre-diabetic or they have metabolic syndrome or something like that. So those are some of the things. And I should note that the new onset diabetes is clearly a class effect with the statin drugs. But we use statins because of their beneficial effects. And this is a schematic of all the possible ways that statins help us to reduce ASCVD risk, from endothelial function, immunomodulation, antioxidative stress, antithrombotic effects, plaque stabilization, or anti-inflammatory effects, including reduction of CRP, which we're going to mention in a bit. Clearly a lot of pathways by which these statins are acting to reduce risk. So I'm going to introduce you to a case, and we're then going to follow this case through the rest of the discussion. Mary is a 57-year-old female with a history of hypertension and arthritis. She presents to the lipid clinic because she recently went through menopause and she noted that her LDL went up. Her current medications are amlodipine, acetaminophen, and occasional Advil. She has definitely become less active in the last few years since she went through menopause. She has no exertional symptoms. Her blood pressure is well controlled. And in terms of family history, the only thing she really has of note is that her mother had a stroke at age 64. Her lipid panel shows a total cholesterol of 178, an HDL-C cholesterol, or yes, an HDL-C of 37, an LDL-C of 120, and triglycerides of 118. So where would that put Mary in terms of looking at her risk? So we go to the primary prevention risk assessment. These are from the 2018 ACC/AHA guideline. And the first thing we need to do when we get to these guidelines is do a risk assessment. And they use the pooled cohort equation for this, but I didn't have my calculator right handy. So what I'd like you to pay attention to is over on the left-hand side, the risk enhancers. There's a long list of risk enhancers, and I made them a little more readable here. Risk enhancing factors are pretty important when we're considering risk, and this list is kind of long, but includes premature ASCVD in first-degree relatives. That's males less than 55 and females less than 65. Primary hypercholesterolemia, not including those who would be considered with familial hypercholesterolemia. They're in a class of their own. Metabolic syndrome, at least 3 out of the 5 characteristics. Chronic kidney disease with EGFR 15 to 59. Chronic inflammatory conditions such as RA, psoriasis, and HIV, etc. Or premature menopause, that's age less than 40, or preeclampsia or other disorders of pregnancy also increase risk. There can be high risk race ethnicity, such as South Asian ancestry, lipid abnormalities, such as a persistent elevation in triglycerides, elevated CRP, which is considered greater than 2, high sensitivity CRP that is, elevated Lp(a) greater than 50 milligrams per deciliter, and elevated Apo B, 130 milligrams per deciliter, or an abnormal ABI. So if we look at Mary's case, we now have our risk calculator out, and she has a 10-year risk of 4.2% and a lifetime risk of 39%. And we now know her CRP as well. It's 2.1%. So I want to ask if anybody feels that now is a good time to put Mary on a statin. Anybody think now is a good time? Maybe. Okay. So we go over to our 2022 ACC consensus decision pathway. And we now know that Mary has, her risk stratification score was 4.4, which would put her in the low risk category. However, she has some risk enhancing factors, such as her mother's stroke and her CRP is elevated. So I would argue that she sort of should be shifted over to the borderline risk category. And for that category, there is a suggestion that you should use moderate dose statin to reduce the LDL cholesterol to less than 100. So we put this to Mary, and she says, no, I don't think I'm ready yet. I think I need some more information, and I want to think about it some more. So she then speaks with her friends, and they say, what about that lipoprotein(a)? Did they check that? So I'm going to speak for a minute about what lipoprotein(a) is and what it means. Lipoprotein(a) has been around for a long time. It was actually discovered 61 years ago by this handsome gentleman, Carberg. He was a Norwegian. And he was looking at something totally different when a signal came up in his lab, and he stopped and figured it out. So lipoprotein(a) is really a modified LDL modified by having an attachment of an lipoprotein A. And those are all the little kringles that you see there. It's attached by a disulfide bond, and the kringle numbers and repeats play some role in their atherogenicity. A part of why we didn't talk about lipoprotein a lot until more recently is that we didn't really understand how lipoprotein A was atherogenic, and that has really been borne out more recently. So it's an independent risk factor above and beyond LDL for atherosclerosis and valvular aortic stenosis. And it's present in about 1 in 5. So that means a couple of you here in the audience have elevated lipoprotein a. It varies by ethnicity, however, throughout the world. The key role in the mechanism of causing ASCVD is felt to be oxidated phospholipids and also inflammation. Unfortunately, our measurements aren't standardized. We seem to have a habit of using multiple different ways of measuring things. So you can measure it in a mass, and that's in milligrams per deciliter, or as nanomole, and that's in a particle form. So the levels that are at increased risk would be greater than 50 milligrams per deciliter or greater than 125 nanomoles per liter. And I'm not going to spend much more time on lipoprotein a, but I will give a shout out to Dr. Mehta, who spoke very eloquently and thoroughly about LP a few weeks ago. And so you can catch that on YouTube. So we did measure Mary's LP and lo and behold, it is elevated. So with that additional information, she was now willing to consider going on a statin. And so she was started on rosuvastatin 5 milligrams a day. And we said, we will check your levels in a few months and see where you are. Unfortunately, she called before a month was out and said, I'm having aches in my legs, and I don't like this medication anymore. So she came off the rosuvastatin at our suggestion, and we told her we'd get back with her in a few weeks and see how she was doing. In the meantime, let's just talk about what we do with people who have side effects on statins. Oh, we have a whole algorithm here, so you know it's not uncommon. And the usual way we handle this is that we stop the statin, see if the symptoms go away. If they go away, sometimes we challenge them again, because once they've stopped it, as soon as you start it again, they should have the symptoms back. And then you know for sure that statin is out. But per this guideline, we should try a different statin, maybe a different type of statin, maybe a much lower dose of a statin. That was a low dose rosuvastatin, but we have other weaker statins that we could try, or even trying alternative day dosing. So we want to make sure that we're giving every opportunity to get a patient on a statin at some level. So if Mary had decided that she is not going to try any more statins, we would encourage her to try a second one. And if she did poorly on that one, we would follow this guideline right here with adults without clinical ASCVD or diabetes. And so they're giving you alternatives to a statin drug. The first line therapy is ezetimibe. Ezetimibe's been around a long time. It's inexpensive. It's well tolerated. And you can get about a 15 to 20% reduction in your LDL with ezetimibe. The second line here are bile acid sequestrants, and they also can give you about a 10 to 30% reduction but there's often a lot of side effects from those, mostly gut related. The third line therapy is bempedoic acid, which is one of our newer therapies. I'm going to spend a minute talking with you about these three. Bempedoic acid, rather. Bempedoic acid will reduce the levels from 20 to 25, maybe 30% as well. So what is bempedoic acid? So it's a small molecule that inhibits adenosine triphosphate citrate lyase, which sits about 3 steps above HMG-CoA reductase in the pathway for cholesterol synthesis. So it acts in the same way. By decreasing the synthesis, it upregulates the LDL receptor expression, and therefore you get lowering in the LDL. The really good thing about this drug is that it's a prodrug, and it's activated by an enzyme in the liver and not in the skeletal muscles. It was actually designed especially for people who had statin intolerance. So there's much decreased muscle-related side effects. And it was approved in February of 2020. And these are some of the results of the study performed, showing a 26% reduction in bempedoic acid. And the other characteristic that they pointed out was a significant drop in high sensitivity CRP with this agent. In terms of their primary endpoints, the 4-component MACE primary endpoint was met with a 13% reduction in hazard. And the 3-component MACE also met significance. One of the things that you should know about bempedoic acid is that we don't recommend use in people with gout because it raises the uric acid level. And that was the most common problem that was seen in the study. There are some people who can be well controlled on medications for gout and are able to take it, but it is not the recommended thing. I will also say that during this study, they had more patients in the placebo arm complain of muscle aches than they did in those in the active treatment arm. So it really is a great drug when you've had problems with statin intolerance. So I'm also going to mention the PCSK9 inhibitors, sort of round out our armamentarium for treatment of ASCVD. PCSK9 inhibitors, the first 2 have been out for about 10 years, and they are both monoclonal antibodies to PCSK9. They work by reducing the PCSK9, which increases the LDL receptors, and that in turn increases the clearance of LDL. The evolocumab and alirocumab, those 2 will reduce LDL by about 60%. The third agent, inclisiran, has not been out quite as long, and it will reduce LDL by about 50%. It is given twice a year in the clinic after the initial 2 doses. So it's great for people who travel or people who have difficulty giving themselves an injection. Whereas the other 2 are given by an auto injector twice a month. And one thing to be noted is that LPA is reduced 20 to 30% with PCSK9 inhibitors. Not that that's an indication for use, however. So here's sort of a summary slide, just looking at medications that decrease LDL or Apo B. The statins decrease they all decrease risk. There is a slight increase in Lp(a) with people treated with statins. It's not felt to be significant. Of course, PCSK9 reduces risk in Lp(a), but it has no effect on CRP as the other ones do. So I'm going to switch gears here and talk about apolipoprotein B. And I know you're all excited about this. It is very important, however, because the rest of the world is using Apo B more and more, and I think you're all going to be hearing more about this in weeks and months and years to come. So what is Apo B? It's the main structural protein on all the atherogenic lipoproteins. And it's also the major ligand for the LDL receptor. So it has some pretty important duties here. Also, there's only one Apo B molecule on each atherogenic lipoprotein, which means when we get an Apo B level, we're basically getting a score of all the atherogenic proteins. And we don't have to worry about the LDL being off. And I'm going to go into that more in a second. In short, though, Apo B and to some extent non-HDL stratify ASCVD risk better than LDL does. And here's just a little diagram or schematic of what it looks like. What are these Apo B molecules that we're looking at? So they include apolipoprotein B, which is the VLDL, IDL, and LDL, and apolipoprotein B48, which is what comes in from the gut in the form of chylomicrons. So all of these are directly measured in a particle way. So it makes a difference because LDL cholesterol is measured and varies day to day within individuals, size and composition changes. And the change in these values of LDL occur more if you're on treatment with statins or you have a very high or very low cholesterol content in the LDLs. Which you can't really tell. And I have a schematic that we're going to go through in a second. But if we are getting readings of LDL that are not accurate, that means that our classification of patients' ASCVD risk is not accurate, which means we may be under-treating folks. So I'm going to go through this schematic with you. In the upper right corner, where there's high Apo B and low LDL cholesterol, so they are not in sync. It's due to the fact that there are a lot of particles there, but the LDL is lower because the particles are smaller, so they're carrying less cholesterol. Versus on the upper right side, where there's high HDL and high Apo B, there's big particles and there's a lot of them, so they are congruent. In the bottom left corner, there's low Apo B and low LDL cholesterol because there aren't a lot of them. And so they're congruent in that category too. But in the far left, lower left, lower right hand, there's high LDL, but low Apo B. And that's because there's only a few, but they're really large particles full of cholesterol. So this is why Apo B is able to tell the risk better, because the risk follows Apo B and not necessarily LDL cholesterol. So if we were to use Apo B to help us determine therapy and thresholds of therapy, we have to know the numbers. So if you had someone who was borderline to intermediate risk, and their cholesterol was, their Apo B, sorry, was greater than 90, then they should be placed on therapy. Likewise, if they're high risk and their Apo B is greater than 70, then they should be on therapy. Or very high risk, their level should be less than 60. And so if they're not at that point, then you would put them on therapy. So all of this has come to pass because the National Lipid Association put out this consensus guideline recently. And I think that's the initial step into getting it moved into likely the ACC, AHA guidelines in the future to come. So in summary, Apo B is part of our routine assessment in the lipid clinic. It has not yet been endorsed in the US guidelines, but it is part of the Canadian and European guidelines. It's definitely not experimental. It's been standardized. It's available in the labs. Here at VCU, we send it to LabCorp. And this consensus statement gives us support for use, makes us able to support our patients if the insurance company won't cover it. But I think you're going to be hearing more about this, and hopefully you can take home a little bit with you from today. So back to Miss Mary. We just wanted to let you know that we had measured her Apo B. We just didn't tell you. She has an elevated level of 104. So that adds to her risk. So now we're going to switch gears here and talk about coronary artery calcium. Coronary artery calcium scores have been available for quite some time. It was developed by Dr. Arthur Agatston and his colleagues. And when this initially came out, I clearly remember a lot of people felt that this was kind of a gimmick, and they were concerned that we would make the public worry too much because they might have a high score, or that it was just being done so that you could get a high score and then you could do a bunch of procedures. Anyway, all of that died away pretty quick when people realized how helpful calcium scores could be. So it is best used in the intermediate risk patients, and it was first mentioned in our guidelines in 2013. So here exactly is what it looks like in the guidelines for those with intermediate risk. And we're going to go over what all the levels are, but basically the guidelines say that if you have, it's a class 2A from the ACC/AHA 2019, but if you have this, it can be used in your shared decision-making about putting patients on a statin. But after you do your risk assessment and your risk enhancing factors consideration. The 2022 expert consensus decision pathway suggested that CAC measurements would be useful in adults without disease for patient hesitancy, meaning they're not really excited about being on a drug, or MD uncertainty about initiating medication. So a very good open way for us to be able to use these this technology. So we talked to Mary because she's still not on any medication, and told her that she got her CAC score. It was 38, and that puts her in the 85th percentile for her age race, and gender. We suggested that she might want to consider being on a statin. So here, in fact, are the CAC score guidelines here. So on Miss Mary's case, she has a CAC score less than 100, but it's greater than 75. And so that percentile puts her now into the moderate intensity statin requirement. So she's moved up a level. She now should have an LDL less than 70 from the guideline standpoint. But this CAC score goes from 0 to greater than 1,000, and we're going to go through those levels. But first, I want to talk about the numbers that you get from the CAC score. You get the absolute number, which works well in somebody who's probably older than 55 or so, but is more of a short-term 5 to 10 year score. And then the percentile is better for younger patients because you might have a relatively low score, but if you're only 35 or 40, that score would actually be elevated for your age. And thus the percentile score is really important. So, and it's also a better longer term risk assessment. What I will say is you need both, and you get both in the test that when it's returned. And here are the levels, low, medium, moderate, severe, and extreme risk levels. Mary had a score of in the 30s, but she was above the 75th percentile, so she's in the moderate range. Typically, if the score is 0, unless they have risk enhancing factors, most people would not treat them. And we'll get back to what we do with those patients in a minute. But I wanted to point out the bottom of the slide. Having moderate risk gives one 10 times the risk of having an ASCVD event as compared to someone who has a calcium score of 0. So it's very powerful risk enhancer, if you will. This is what a CAC score result looks like coming back from the radiologists here at VCU. You can see they divide the coronary arteries, left main, LAD, left circumflex, and right coronary, and they give a score for each one. The total score is reported, and then also the percentile. And I will tell you that oftentimes people get worried when they get these scores and they find out like all their plaque is in one vessel. It's like, oh no, I'm going to have a heart attack in that one vessel. It really isn't a marker of where there's active problems. It's a marker of the calcification. So we don't typically look at where it is. We're just looking at the severity of the overall disease. And then we have the case where we sometimes get a CAC score for free. And by that, I mean somebody gets a non-gated CT scan of their chest. And now our radiologists are reading out a semi-quantitative report by how many segments of the 4 coronary arteries are involved. This one, of course, was a score of 0, but each vessel gets a score of 0 to 3. And so the absolute max score would be 12. So if you get one of these back and or they've had it and you notice it when you're looking in their imaging section, you don't really need to do a CAC score. This is like having a CAC score for free. It's quantitative enough to give you the information to use to figure out what to do for your patient. And a lot of times we get referred patients who've had a CT scan, they see all this calcium, and then they say, oh, well, you've got to go get that figured out. So because this is such a helpful tool, there is a group from the Right Care Initiative who's putting together a staging. And this is sort of their, it just came out, this is sort of their idea of how we should stage coronary artery calcium. And it's meant as a guide, similar to staging that we do for heart failure or we do for cancer, or in fact, they mentioned that coronary calcium is used in the new staging for the cardiovascular kidney metabolic syndrome pathway. And again, it's important to remember we have to look both at the absolute score and the percentile. So this is their staging, very similar to the staging we saw before. The calcium score of 0 puts them at low risk, but they recommend that you emphatically get them to have improved health by using the American Heart Association's Life Essential Eights. And then they talk about when you might repeat this. If somebody has diabetes or a high 10-year risk, you might repeat it in as little as 3 years, 3 to 5 years for intermediate risk, or 5 to 7 years if it's low risk. I know that they've been watching diabetics more recently, doing repeats to determine how fast, if they have plaque, how fast their plaque is growing. But the rest of these are the same as we saw previously. In the moderate range, again, they recommend that you should achieve an LDL goal less than 70, and perhaps consider adding low-dose aspirin. Those with higher scores do recommend low-dose aspirin. And in the highest score, where we still are saying in the US, an LDL goal less than 55, you might consider even lower, more of the European guidelines. And you might consider emerging therapies such as low-dose colchicine. So we can't finish the discussion about coronary calcium without talking about its cost. And it is not covered by insurance here in Virginia. And in this area, it costs about $100, specifically here at VCU as well. In larger markets where there's more competition, it could be half that, but it can also randomly be a few $100s somewhere. So they mandated in Texas that they would cover part of that on federally funded insurance plans. And in New Mexico, there were 2 doctors who fought to get it covered for those over 55. And so that's our next attempt at getting something done about that. But the reason that it's not been in all the plans, it's the reason they don't cover it, even though it is a really helpful tool and it's been used for a long time. Part of it was stated that it was not in the guidelines. Well, it has been in the guidelines for quite some time, so that's false. And then I found some information that the U.S. Preventative Services Task Force doesn't endorse it due to insufficient evidence and possible psychological harm. So what we do know is that the cost provides a barrier for our patients, and maybe we can do something about that through grassroots techniques. Real briefly, I'm going to mention, we only have a few more minutes, the use of CAC score for something I found was quite unique. They tried to use CAC score as a measure of healthy versus unhealthy aging. in the over 75-year-olds involved in the atherosclerosis risk and communities, or ARIC group. So they took all the 75-year-olds or older patients. They got them a FACC score. The really interesting thing is that 10% of them had a 0 FACC score. So there's hope. The highest, greater than 1,000, there was about 20% in that group, and all the rest were in the middle. Mostly these were females, and the mean age was 80, and most were white. And what they did was just look at 7 domains of aging: cognition, hearing, ABI, pulse wave velocity, forced vital capacity, physical functioning, and grip strength. And they did show that there was clearly a difference between those who had a FACC score of 0 and those who had a FACC score of 100. I don't know what happened to the people in the middle, but I just thought it was a very unique way of using a FACC score to try to figure out who's not aging well. So to summarize Mary's case, her goals of treatment, she was initially considered low risk. Then we added the risk enhancing factors, made her more borderline risk. And then finally, the FACC score elevated her to a moderate risk. So just over the course of trying to get this patient on the right medication, we saw a lot of variability, but you keep moving forward and you keep getting more information so you can provide the best care. At moderate risk, the goal of her therapy becomes an LDL less than 70 and an Apo B less than 90. So overall, in summary, we always need to keep reassessing risk over time. And we use risk in all of our decisions with our patients every day. I think we just don't really even think about it. Overall, Apo B is a better risk evaluator than LDL cholesterol. And FACC scoring is a very useful tool with minimal harm. And with that, I will open it up for questions. Thank you.
The questions here. Hold on. So our online audience can hear.
So I had a question about, with a FACC score of greater than 300 for those patients that have never had a true ASCVD event, and starting them on aspirin, is it considered primary prevention at that point, since it's not a known event that they've noticed, just like when it goes to time of counseling them for like taking the aspirin and everything?
Yeah, so I guess I didn't mention it, but once you get to the FACC score of 300 or higher, that's the equivalent of having had an event already. So we do sort of escalate them up as if they've had an event, and that's why the addition of aspirin would seem to be appropriate.
A question about risk and thinking about this with patients. So I've always struggled with the calculators because they give you, the 10-year risk, but then they give you the lifetime risk, and the lifetime risk is always much more impressive, obviously. Yeah. And we know you cut the risk in half or so roughly with statins, maybe a little less. And so when I look at the big number of lifetime risk, it just sort of, I'm always like, well, maybe we should just be putting everyone, particularly Mary, who's 57, will probably live for another 30 years on a statin without even thinking too much. And so I'm wondering how you think through that, because it's just this thing that I always find jarring to look at, over to the right and see the bigger number.
I guess when I look at the lifetime risk from the calculator, first of all, I think there are weaknesses in our pooled cohort equation for sure. And we're trying to get better and better at that. But when I look at that, it tells me that right now, even though her risk was low, there is something in the characteristics of her position, her status, that is going to be a problem later on. So even if all of her other studies came back crystal clear and she stayed in that low risk group, I think seeing something that further out looks more scary, shall we say, would make me say that she needs to be followed more closely than just say, oh, you're good, keep doing what you're doing. Just a more closer follow-up. Or you go digging like we did.
Online. Any questions online? If you want to comment on those.
So one of the questions from Stephanie says the concern about bempedoic acid cost does not reflect efficacy at all. You are so right. That's because it's a newer drug and the drug companies are needing to get their money out for all the development costs. And I agree with you that it's as high as a PCSK9 inhibitor, just about, depending on the plan. In addition, I've found that a lot of payers want us to put people on a PCSK9 when bempedoic acid would be just as good for the patient, or is really what they need. They don't need a 60% reduction, they need a 30% reduction. So I think it is difficult to get their costs down. I'm not sure that we can influence that very well. I only know that over time it will come down. But we've been through this basically with all the drugs when they first come out. I remember arguing with Anthem about using rosuvastatin when it was Crestor and it was name brand only. So it is a problem. The second question was any specific therapies shown to reduce the CAC score? No, the CAC score is calcification, and therefore it's there to stay. Basically, we use that score though to give us an idea about how aggressive we need to be in treating all the risk factors because we don't want them to go any higher. And here's a question about reviewing, when reviewing early menopause or preeclampsia, where do these factors play a role in choosing which tests to review or treatment choices? I view all of these pregnancy-related issues as risk enhancers, really. And if somebody comes in and they've had 3 kids and they've had problems with all 3 kids in some way or shape or form, then I really take notice, and I think that we have to look at those patients carefully, follow them, look for other risk factors, and treat them appropriately. In terms of tests to look at, it's really just a matter of looking at all the typical ASCVD risk factors overall. And then we have sorry. So Stephanie's asking, take the PCSK9 in that case, the lower we can lower lipids for longer, the more we will prevent events. I agree. And I think that primary prevention is definitely our goal. We'd like to see people who come in and say, my parents have this problem and we don't want it. Then we can really have, an overarching intervention for those patients. So thanks for all those great questions.
Anything else?